The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everybody. We are here for the next episode of TMD Demystified. I'm Tony Urbanek. Today's topic on a Tuesday morning is TMD and neck pain. As most of you would know who follow this podcast and these episodes, I pick out a topic or a title for every episode and try to take a little deeper explanation into what that's all about. Recently, I have done a similar episode title on TMD and headaches. And knowing that the disparate symptoms of TMD include headache, earache, neck pain, jaw pain, tinnitus, subjective hearing loss, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. My intention is to cover each one of these symptoms over a period of time, maybe not sequentially. I may drop in a different title depending on what I think is important or what I am thinking about at the time. I have so much to say about this topic, primarily because I've studied it for so long, figured out how to treat it successfully by treating the common denominator. The common denominator cause of all of the disparate symptoms that I just mentioned is inflammation within the temporomandibular joint. Inflammation creates each and every one of these symptoms. That is the thing, the discovery, which I didn't discover it. It was in the literature. I just read the literature that the orthopedic surgeons had known about for 70 years on how joints operate. Temporomandibular joint operates like any other joint in the body. It is not different. It's not unique. It has a little different, unique name, gynecoarthroidal joint, but it's not any different in its pathophysiology, in its biochemistry, in its cell biology than any other joint in the body. And that is where dentistry went astray, big time. And it's continually is being taught in dental schools that this joint is unique, different than any other joint in the body. No wonder they couldn't find actually a cause, the common denominator, when they're talking about how different it is. In any case, I did make those discoveries in the literature and connected the dots, and then developed a very simple device that unloads the temporomandibular joint just like a set of crutches unloads the knee. And if you unload a joint long enough, then the inflammation, the chronic inflammation, will dissipate. And when the chronic inflammation dissipates, all the symptoms go away because the symptoms are directly caused by chronic inflammation. So we cover each one of these topics. In today's case, we're going to talk about the specifics of neck pain. Neck pain is the second most common symptom of temporomandibular joint disorder. Headache is number one. Headache is the most common, and I covered that last week. If you want to read, it's on our website, our blog on this issue, and the podcast was recorded a week ago. But today, we're going to talk about neck pain. It's very similar, obviously, or maybe not so obvious, how neck pain and headache are brothers and sisters, actually. They're so similar in almost identical in the way that they are created by chronic inflammation within the temporomandibular joint. I've discussed this before. This is clarified on at least 2 prior episodes on TMD Demystified, published on Dental Town and YouTube. But I wanted to do a little more thorough investigation, and because of this new tool that we all have, which is artificial intelligence, which is very neutral in the way it addresses issues. It, like me, just goes back to the literature and pulls out the appropriate information from its memory, which is obviously a very broad memory, artificial intelligence. And you can query, as you know, anything you want and get a adequate, correct, although it can make mistakes, that has to be, validated, but gets into all of the different substances of anything that you want to ask. So today I ask artificial intelligence, my AI, I've given it a name, which is Rene, R-E-N-E apostrophe, Rene, as in Rene Descartes. I think, therefore I am. So I call my AI Rene. I think, therefore I am. Cogito ergo sum. So let me just share with you then, and we're going to go through the diagrams that Rene prepared for me to help you understand visually. Visuals is much better, obviously, than just hearing me drone on with words. So I'll go through this point by point. You can read it yourself if you'd like. But how chronic inflammation causes neck pain. And as I said, it's very similar in method and pathophysiology. The same thing causes headache. But first you have chronic inflammation within the temporomandibular joint. Chronic inflammation within the temporomandibular joint has 3 primary considerations or causes. There's 3 things that damage the temporomandibular joint. 3 categories, I guess, is the word I'm searching for. 3 categories. The one that everybody knows about and talks about and focuses on, and maybe too much, is bruxism. Now, bruxism certainly, I think, it's my opinion now, but I think many would agree, I think that bruxism is the most common cause of damage to the temporomandibular joint. Clenching and grinding. You can clench during the day, you can clench during the night, you can brux during the day, you can brux during the night. You do not have to hear your teeth making noise to damage the temporomandibular joint. It's the load, the pressure on the joint itself over a period of time that damages the joint. The other 2 categories, are acute trauma of many, many kinds, especially motor vehicle accidents. And of motor vehicle accidents, whiplash is definitely most prominent cause associated with the temporomandibular joint, because when the neck snaps back, the mandible snaps way open, overextends. Overextension of the temporomandibular, of the mandible, of the jaw, will damage the internal structures and of the temporomandibular joint, especially the meniscus and the tissues that attach the meniscus within the joint. And then the third is functional malocclusion, which by far has not been given appropriate attention by the dental profession as to causing temporomandibular joint problems, because a functional malocclusion overloads the joint. And I've talked many times about what a functional malocclusion is and why it's pretty much ignored by many orthodontists in their attempts to straighten teeth. They're really good at getting the teeth straight, but very often, unfortunately, they do not focus on or consider when you put traction on the mandible, traction on the lower jaw to try to fix or correct a malocclusion, that they're overloading the joint. And you do that long enough, you will damage the joint, which leads to chronic inflammation, which leads to temporomandibular joint symptoms. So there are 3 categories: bruxism, acute trauma, and functional malocclusion that damage a joint. Once the joint is damaged, that inflammation is the body's attempt to straighten it out, to heal. And we all know that when you cut yourself after 2 or 3 days, you see a little red line on either side of the cut, which is the body's attempt. That's inflammation. And inflammation has certain characteristics. One of them is redness. The other one is pain. Proper function, bringing back proper function, and swelling. Those are the 4 categories of regular healing inflammation. But if it doesn't go on to heal, if whatever causes are still there or still creating a problem, or the problem is too severe in nature, then the natural healing type inflammation and cellular types of natural healing type inflammation convert into a different cell variety and different cell exudates, which actually can further damage the areas around chronic inflammation. And so you have a damaged joint, you get chronic inflammation, synovitis, capsulitis of the or internal derangement, meaning the meniscus itself is out of position when the ligaments that hold the meniscus get loose because of the chronic inflammation. It starts to click, and then it starts to degenerate, and then you can get the meniscus getting beat up, and you get a hole worn in it, all kind of things. That irritates the nociceptors within the joint itself. The nociceptors are the pain receptors that are located in the periosteal tissues associated with the joint. That in turn stimulates the afferent, meaning toward the central nervous system, afferent, A-F-F-E-R-E-N-T, sympathetic stimulation toward the brainstem. The nociceptive input travels via the trigeminal afferents and associated pathways to the brain stem. We're going to talk about the brain stem here at the end, and I think I have some very profound things to say about what happens in the brain stem. I want to talk about that even more than I want to bring this information is how you get neck pain, because it really all boils down to what happens in the brain stem when those afferent signals come into the brain stem and then get modulated, understood, and then come back out as efferent signals, efferent neural signals. But in any case, so you have your signal in the brainstem, the autonomic signals in the autonomic areas, autonomic centers of the brainstem. The efferent, then, sympathetic response is the brainstem sends efferent sympathetic output to the neck muscles, and instructs the muscles to get tight. Why is it giving this signal? Because it's trying to help that joint to heal. It understands, the brainstem understands, it got a signal. The brainstem says, I got it. The joint is damaged. The joint is chronic inflamed. We're going to help you. Don't move this joint. The best option that we can give you is hold the joint still and allow it to heal. Like any other thing in the body, if you have a broken bone, the first thing that the body is trying to do is hold that bone together in the right spot. Sometimes they need an orthopedic surgeon to help out with a splint or a screw or a plate or two, but the whole point is hold that still, and you're getting these efferent signals to hold the temporomandibular joint still. When it does that, then that stimulation of the periosteal nociceptors of the muscles where they attached to the bone. And in this case, the neck muscles get signals to get tight. The signals first come down to the muscles of mastication, the muscles attached to the jaws. That gives you facial pain and headache, because the muscles of mastication go all the way up into the head. But when that is not enough to decrease the chronic inflammation in the joint, the signals continue to arrive in the central nervous system, and the brainstem says, I'm inflamed, I'm damaged, I need help. And so the signals come down, hold the jaw still, and then they come down and say, hold the whole head still. tighten up everything. And that is why neck pain is the second most common symptom of TMD, temporomandibular joint disorder. By the way, it's one disorder. The doctors that are out there say it's multiple disorders. They're just treating multiple symptoms at very best. And some of those are not effective at all, or if they're effective for a very short period of time. And the worst of the worst is Botox. I have a lot to say. That would probably be a whole separate episode. So you stimulate the nociceptors, where the muscles that control the head and hold the head motionless. And those muscles are the strap muscles on the side of the neck, the sternocleidomastoid, which is a big muscle that's attached right there, the trapezius across the back of the head. And patients will report every morning, they'll literally point to the insertion of the sternocleidomastoid right there at the lateral side of the base of the posterior skull and say it hurts right there every morning. Or they'll point to the trapezius, say that's where it hurts. Or in the lower, where the insertion is, or origin, I guess the insertion would be at the SCM, sternocleidomastoid, but in the upper shoulder, where that large muscle is, and the trapezius is inserted into the shoulder. So the signals are getting to get the whole first jaw, then neck, and then even the upper shoulder girdle tight, to try to hold that joint motionless. And that is why you get these painful feelings where the muscles are inserted into the bone. And that is why you get neck pain with temporomandibular joint disorder. Now, let me go on to the second slide that AI helped me prepare, and basically explains what I did verbally a moment ago, and that how unloading the temporomandibular joint with our device, again, I had to call it the Urbanek Device because I was too embarrassed to call it what my patients wanted to call it. They wanted to call it, we surveyed them. The two number one answers on the hundreds of people we surveyed, they wanted to call it Save My Life Device or Miracle Device. There's nothing miracle about it. It has changed the lives of a lot of people, though, I can say that. Device and protocol. It is a tool to use. You have to use it with the protocol. You can't use it any way you want, but what you're doing is unloading the temporomandibular joint, which reduces the inflammation and neck pain and other symptoms, all the other symptoms also. But why it works is because it separates the functional part, the heavy-duty lifters, if you will, of the posterior teeth, which provide 90% of the loads on the temporomandibular joint, are from the posterior teeth. So if you disocclude the posterior teeth carefully enough, long enough, then the inflammation dissipates. When the inflammation dissipates, the disparate symptoms dissipate, including the neck pain. So the sequence is, number one, unloading the temporomandibular joint with the Urbanek Device and protocol. The device and protocol gently separates the condyle from the socket, reducing mechanical compression and stress on inflamed tissues. Number two, the inflammation subsides. Reduced mechanical stress allows inflamed synovial tissues to calm down and heal, basically change characteristics of that inflammatory cellular response. Again, I just read the literature, but I had the advantage of having a degree in cell biology and anatomy that I got immediately after I finished my dental degree, and before I actually came to Vanderbilt and did my medical degree and surgical training. Step number three, the decreased afferent stimulation to the brainstem. So you no longer get that stimulation in the brainstem. Less nociceptive input from the TMJ reduces the afferent fibers to the brainstem. Number four, there's a decreased then efferent sympathetic output because it's not getting the signal that's so inflamed. The efferent output from the sympathetic system doesn't send signals to tighten up anymore. And when the muscles relax, it quits pulling on the bone. That's step 5. And the ultimate is that the symptoms dissipate and go away. That is how it works. It's not any more complicated than that. So let me share this third diagram slide that AI produced. And this one, I'm going to leave it up as I speak here. I'm going to talk about it. And it is pretty amazing to me once I got into it and applied some of that knowledge that I gained getting a degree in cell biology and anatomy as to how this applies to some of the other symptoms that are not well known and that need more study. I must admit that need more study as to prove how there are additional disparate symptoms that go along with temporomandibular joint disorder. The one that is, I think, in my mind, most important to discuss, and again, this can be proven, and there are some studies that can easily be done. I myself and my company have limited resources, and we apply our resources as best we can. But I encourage anyone who would like to do this study to contact me because I think it'd be an excellent university study in both the professional end of it, in dentistry itself, or even in undergraduate. Because here's the situation. Migraine headaches are well known and differentiated from any other kind of headache because of visual disturbances. We call them aura, A-U-R-A. The medical doctors treat migraines with drugs, all kind of drugs. Most of those drugs, what they're doing is suppressing the entire nervous system. You take a drug for headaches, and you're not only treating your headaches, you're treating your entire nervous system, suppressing the nervous system. In the case of its hopeful effect on headaches, it depresses the nervous system to the point where you don't get the painful part of the headache. But the other feature of migraines is that the medical establishment fully admits they do not know what causes migraine headaches. They admit that. Every scientist who works on this admits we do not know what causes migraine headaches. Medical doctors, my medical compatriots, throw drugs at it and see which one might work better. There are a lot of theories about what causes migraines, but they admit they don't know. However, we know on the dental side of this that chronic inflammation within the temporomandibular joint, better known as TMD, creates bad headaches. And these bad headaches are constantly misdiagnosed as migraine headaches rather than TMD headaches. Well, the distinguishing factor between, an historical distinguishing factor between migraine headaches and any other kind of headache has been classified as having a aura associated with the headache itself. And some of these auras are visual disturbances that can be literally caused by stimulation in the brainstem of some of the muscles that move the eye. At the same time, the signals come down to hold the whole jaw still and hold the whole neck still. I propose, I establish that it is possible that those visual disturbances actually caused by the signals coming down and intermixing with the signals coming out of the brainstem that cause muscle tension. In many people, I have seen that many times, complaining of pain behind the eye where the muscles are inserted, of the eye muscles. There are 3 categories of eye muscles. There's the muscles that are moved by the ocular motor nerve, and then the trochlear nerve, and then the 6 nerve abducens. There are 3 different cranial nerves that move the eye. And any one of those muscles or set of muscles, oculomotor muscles or several muscles, the abducens is just a single muscle, but they have their own cranial nerve originating in the brainstem right there along with the nuclei that operate the trigeminal nerve, the third cranial nerve. So, that study can easily be done, but this diagram that AI did a wonderful job creating can show technically how once the parasympathetic, the sympathetic afferent signal arrives in the brainstem can be confused in the reticular formation. That's the general formation where all of the nuclei of the cranial nerves arise, the reticular formation, and that there can be cross stimulation between the different nuclei, and when and if that nuclei of the ocular motor or the trochlear or the trigeminal nucleus, trochlear or abducens nucleus are also stimulated, then you get an attempt to hold the eye motionless, and you will get visual aura of various kinds. That is very, very possible, and I believe very likely, and will explain why, even though patients complain of aura, it's not migraine headaches, it's TMD headaches. This same confusion coming out of the reticular formation can also apply to the facial nucleus, which is the seventh nerve, the eighth nerve, which controls the vestibular mechanism, the mechanism for keeping your balance, and also hearing, and then the glossopharyngeal, which is 9 and 10, glossopharyngeal and vagus, which can create tightness in the throat. Again, I have had many patients who have hot joints. You can tell that they have TMD. They have the plethora of other symptoms, but the one that is not on the most common list is I feel like I'm having trouble swallowing. I feel tight in my throat. That certainly could be explained by stimulation of the 9th and 10 glossopharyngeal or vagus nucleus. So I think that much more study, and these studies can easily be done by coming up with a group of patients who have been diagnosed with migraine headaches that have some of these other symptoms, and finding how many of these patients who have have been treated for migraine headaches actually exhibit inflammation within the temporomandibular joint, creating all the other symptoms. How many patients in that subset of patients with diagnosed migraine headaches also have other symptoms like subjective hearing loss, dizziness, vertigo, upper back and shoulder pain, neck pain, arm, hand, finger tingling and numbness, which we already discussed. How you can get arm, hand, finger tingling and numbness from stimulation of the muscles, the strap muscles, the scalene muscles on the side of the neck, squeezing the brachial plexus, stimulating numbness and sometimes pain and tingling of the fingers and wrists and forearm, and even up or higher into the arm, where the brachial plexus inserts into all those muscles. So that is what I have to say about neck pain and TMD. It's obvious. I am beside myself sometimes as I go through this, as I look at the anatomy, as I look at what I've learned years ago about cell biology and how this joint operates like any other joint in the body, how all of this has been missed by the dental profession, and that to this day The standard of care is to just treat symptoms and treat them in sometimes the most unusual, non-productive ways. The nicest thing I can say about Botox is the people who produce the Botox, which is a drug company, pharmaceutical, have a lot of money to spend on advertising. And that is why the use of Botox for the treatment of temporomandibular joint disease is so prominent. And they have convinced not only the dentist. I had a patient tell me that her primary care physician is now treating what was already diagnosed in her case many years ago. I think in her case 20 years ago, and her primary care physician is injecting Botox into her face for temporomandibular joint disease, which is just treating whatever area is hurting at that time, paralyzing the muscle that is hurting. And you can paralyze the muscle and it won't pull on the bone, but you got to go back every 3 months to get that injection. I've had patients, the worst I've ever heard is $200,000 over 10 years. And she said, I'll bring in the receipts. And she's sitting there after 10 years and $200,000 of Botox in and around her head and face with the same symptoms. You can see why I might think that Botox is not an appropriate treatment. All right, neck pain, TMD. I hope bringing this to your attention and simplifying it with a little diagram will make it easy for you to understand how this works, why it is scientific and appropriate. So I appreciate you being here. I appreciate you paying attention. I like to keep these presentations and these episodes to about 30 minutes. If anyone would like to find out more about this, you can go to our website, www.urbaniktmj.com. If you are a dentist who would like to be able to do what originated here in Middle Tennessee, and now we have doctors in 20 states who are licensed to use this device and protocol. It is patented, so you have to take a little course, learn how to use it. Any dentist can do that. You can take an online course or come every quarter. We have an in-person course here in Franklin, Tennessee, and you can learn how to use the device and protocol safely. Not a problem, as long as the patients cooperate and use the protocol correctly, 24/7 for 2 months, and nighttime only the rest of your life. Study our already produced university study done through Middle Tennessee State University that actually has proven statistically the high success rate, actually stunningly high success statistics regarding this device and protocol. www.urbaniktmj.com. With that being said, I encourage anyone to contact me if you'd like to be on this podcast as a guest. Please do. I can be reached at tony@tmjservices.net. If you'd like to criticize, make sure you bring your statistics and your science with you. If you'd like to comment or ask questions, I refer you to our live stream, which I produce every Saturday at noon. I also produce a live stream and invite live viewers to make comments, to ask questions, and if you want to criticize, no problem. With that said, thank you very much. I look forward to next Tuesday. I am Tony Urbanek, and this is TMD Demystified.